So I think, okay. So now we'll go straight to our last Q&A. And I thought we could start with a couple of questions from the Zoom, from online. There are two related questions here that I thought maybe you could answer, David. One from Lee is about whether Medicare for All will cover catastrophic medical costs, irrespective of whether or not an individual has at least some insurance. And then a related one is another attendee said they've had experiences in which Medicare has denied payments for some treatments if there's no improvement from the treatment, even if the treatment prevents deterioration. And will that be a risk for a Medicare for All system? And who will make decisions about medical necessity? I think those two are potentially connected, and I thought you could maybe address them.
So as for the first one, as it relates to catastrophic medical conditions and needs and services, the answer would be yes, that it would be covered, because a condition, a major condition and provision in the federal waiver that we received from the federal government giving us permission to establish a single payer healthcare system is that in quote unquote unique circumstances as it relates to medical needs and services, the federal government would be able to cover those costs. And in terms of the second question, as it relates to Medicare and some of the coverage in terms of that, from my understanding, again, it would be a conversation that would have to be had with the federal government in terms of being able to outline what would and would not be eligible. Because again, our goal and focus is to make sure that we're able to cover all medical services. Again, there is an argument currently going on in our Medicare system about what is considered quote unquote medically necessary versus not medically necessary. So alongside our Executive Office of Health and Human Services and conversations with the federal government, we'd be able to get further clarity on that second question that was asked.
Oh, you want a little more clarity from me, you said?
Yeah.
Oh, so I think the question was about who makes the decisions about what is covered, and I think you answered that. It's a conversation with the federal government.
Yeah. So in terms of what would be covered, it would be again the state and the federal government coming together on an agreement with the waiver. And it would be outlined what would be covered in that system. And that would be dependent on the legislation that we currently have in place, which is as comprehensive as it can be. So when drafting the legislation, I do want to know it has not been introduced yet, but will be introduced within the next 2 weeks as we're just finalizing some of the different finances and metrics in it. We're going to include all medical services that are necessary. And we want to make sure that Rhode Island has as much discretion as possible when it comes to that. In terms of any road bumps that we run into the federal government and what they're willing to provide, again, I understand it's going to be a conversation that would have to happen between the governor's office, the Executive Office of Health and Human Services, and ultimately whatever administration is currently in power at that time.
I have one more question from the Zoom that I want to address. This is from Bella, who has read through the PNHP FAQs and last year's bills, House Bill 5628 and Senate Bill 233, and is concerned because she does not see where it says what people are going to pay. She specifically says she's concerned that the bill will only help the middle class and not poor people, single, low income folks, or the elderly. She's concerned about folks on Medicaid being able to keep their coverage, and she wants to know what the co-pays will be, what the expenses will be, and how that's actually outlined in the bill.
Yeah, so I want to be clear that under this Medicare for All ride-ship insurance program, it would essentially be the benefits of being enrolled in the current Medicaid program that exists, but with further coverage. And at the same time, ensuring that we keep what is currently in place without any out-of-pocket expenses as it relates to prescription drugs, as it relates to hospital visits. At the same time, also making sure that there's no provisions in there as it relates to deductibles. So in terms of like, would someone be able to keep the current Medicaid program or service that they have? It would replace it with, again, a more comprehensive version of Medicaid that has more coverage as it relates to vision and dental.
Just to add on to what David just said, one of the problems with Medicaid in every state really is that since it is a program that exclusively serves the poor, it is always a target for budget cuts, as it has been in Rhode Island for the last few years. when you have everything, every person, wealthy or not wealthy, on the same insurance plan, no one has an incentive to cut funding. You don't poke a hole in the hull of the boat you're floating in. So Medicaid, you know, as David pointed out, Medicaid has been cut several times in the past few years. And it is cut because it's such a large percentage of the state budget is a tempting target for politicians. If you have a single payer national plan, that temptation doesn't exist. Again, if our congressmen have the same insurance plan we do, they have every incentive to make sure that it's maximally funded. One thing that I've never seen historically is Congress cutting its own benefits. So we need a system where we're all equally invested rather than having this balkanized system we've got where I don't want to pay taxes to support those old people and I don't want to pay taxes to support those poor people. And I've got this really good system, this good plan because I work for a large corporation, but you, because you're working for a grocery store, you know, with 2 stores, well, tough. That goes away when you have a national health insurance system. And again, the state system, which I will remind people, that's how Canada got there. Canada started with one province, Saskatchewan, which had a population of 1 million people, roughly the size of Rhode Island. And they ran their provincial single payer system for 8 years before it was finally nationalized. And they ran it very successfully, which is why it was nationalized.
Go to the room now.
Perfect. Well, with that, we can go over to community questions for people who are in attendance. There you go, Doctor.
It's Dr. Dennison again. I'm just going to start out by pledging my help and that of my wife. She's a pediatrician for your effort. Her parents supported this movement starting in 1998. She was head of the visiting nurse, Jane McKenzie. So we're definitely on board. But I want to make you aware of the thing about Medicare. I do a physical on a Medicare patient when they turn 65. And I say to them, the most important thing is to remember this, that Medicare is a lot like a hospital gown. And they'll say, why is that, Dr. Dennison? And I'll say, because you don't always get as much coverage as you'd like. Okay, you got to wear 2 hospital gowns, one in front and one in back if you want complete coverage. There's a very important thing that you all need to know now, and you can do something about it now. If you fall and go into the hospital and break your shoulder, you'll be put on observation. And because you fell and because now you can't use one arm, you're really not a candidate for a safe discharge. You will come to my facility in East Providence, Evergreen, and you will not activate your Part A benefits. And you will get that bill that I told you about, $400 a night. In a month, when you're not ready to go home, because you probably do have some problems, you're going to have a bill between $10,000 and $12,000 because you did not activate Part A. So the key is to tell your doctor, if they don't make you a full admission and keep you for 3 nights, your head has to hit the pillow 3 times. You're going to sue his ass off, and you're going to get a lawyer on South Main Street to make it happen. And it's very adversarial, it's very uncomfortable, but this is no time to be a nice guy, because there is probably something wrong with you. You might have aortic stenosis or something else that's making you fall. So you have to be forceful. So this is an insane Medicare rule. Medicare is not perfect. It has these gaps. And you're one of my audiences here because you're in the role of reformer. You can understand that we've had no success in doing anything about this with the federal Medicare. We have complained for years and they refuse to do anything about it. So this is the kind of gap that is ruinous to older people. And I hope you can do something about it. Do you think you can do anything about that kind of a gap?
Thank you for that. And yes, again, I want to be very clear that as stated by the doctor, there are multiple Medicare programs that exist: Medicare Part A, Medicare Part B, Medicare Part C, Medicare Part D. And I want to be extremely clear that with our improved Medicare for All healthcare system here in the state of Rhode Island, the goal and the way the legislation is going to be written is that we have that full coverage. Because yes, there are gaps that exist, and that's why that federal waiver is so important. And whenever we're able to ensure that the state budget is, again, reflective of our healthcare needs, and we're able to maximize the reimbursements, we're able to eliminate the Office of the Health Insurance Commissioner, we're able to eliminate Health Source RI and all the bureaucratic meat that currently exists and is taking up space in our state budget, that's when we're gonna have that funding that is necessary to make sure we're plugging in those holes that currently exist. And as it relates to our federal Medicare program, you are absolutely correct. That's why it also urged everyone to continue contacting our federal delegation, whether that's Senator Jack Reed, Representative David Cicilline, Senator Whitehouse, and letting them know as well this should be a priority that they're focusing on, not only supporting Medicare for all, but in the short term as well, also making sure that we're making these improvements on the current Medicare system that exists that again leaves people vulnerable.
Just to answer Alan's sort of another point to Alan's question, Medicare has gaps in it because they're deliberately put there. For instance, the vast majority of people in the country who get tetanus are over the age of 65. Medicare does not cover a tetanus vaccine unless you're injured. Medicare also doesn't cover the new shingles vaccine, even though the vast majority of people who get shingles are over the age of 65. As I pointed out in one of my slides, for at least the last 30 years, there has been a concerted effort to defund Medicare. Medicare, as the Center for Medicare and Medicaid Services, have to take the budget that they're given by Congress and apply it to the amount of care that they provide. So when the funding keeps getting cut, they have to find ways to pay for the care that they do provide. So what we're seeing is a very artificial and very deliberate effort to make Medicare work less well, so that in the words of Newt Gingrich, it will wither on the vine and people will leave it voluntarily. That is what they hope to accomplish. So of course Medicare has gaps in it. They're there on purpose.
We have time for one more question, and I see 2 hands up. So Donnie, I will make sure that you are actually our last question. So we're gonna make it 2 more questions.
Thank you. I have a question mostly for Dr. Ryan, no offense. With Congress as it is now, how do you convince our government to actually institute a national program? Because this all sounds very good. I can't even imagine all Democrats supporting this idea, never mind crossing the aisle to get some Republicans on board, which will be necessary to establish such a program. So what kind of conversation has to be had to actually get our government to make such a move?
This is actually a David question, but I'll answer my part of it. I'm not going to give it to David. So what has to happen? You guys have to happen. You have to get in your legislators' faces. You have to be impolite and rude and everything that Episcopal people are never. So unfortunately, who is currently influencing our Congress? People with a lot of money. Who doesn't want national health programs or any programs that don't benefit wealthy people? The people who influence Congress. So the only thing you guys have is your vote and your access to your legislators. Right now, 3 of our 4 federal legislators say and have signed on to single payer bills. The only one who has not is Senator Reed. Linda and I have gone and had really fun conversations with Senator Reed several times, which we give factual arguments, and we're usually met with such platitudes as, you can't make the perfect the enemy of the good. He has no reason for not supporting this other than I have no idea why. So to change the minds of the people who can't be bothered thinking about it or who are financially advantaged by not thinking about it, the only remedy is for the electorate to get in their faces and tell them to actually do something for the good of the people of this country and not for their political careers. David, this is a you question, so I'm sorry I took part of it.
No worries, Mark. I do want to know, a decade ago, we were not having these serious conversations about Medicare for all. I want us to be very conscious about that the discussion around Medicare for all and how we get there has transformed. We have evolved, and we have now, again, the information and the financing necessary to actually establish this program. So at this point, it is the corporate influence that is preventing us from actually getting there in the first place. And what really keeps me optimistic is the fact that across the country, more and more people are running for Congress, are running for local offices on a platform of Medicare for all. So it is no longer a quote unquote pie in the sky idea, but instead we're now in a position where it is a serious policy consideration that's going to transform the healthcare system in states starting like Rhode Island, but across the country as well. And a good example is the fact that I'm very grateful to be serving my first term in the State House of Rhode Island, and I was very proud to introduce this Medicare for All bill last year, and we'll be very excited to do it again this year as well. And I hope to see you all at the committee hearings. But to round us out, Donnie, would love if you could take the last question.
Yeah, David's such a good politician. He wouldn't allow one of his constituents to raise their hand and not be recognized. So I think this is a simple answer. It's just that I didn't hear anybody address this, and it's such a critical concern. And that is, could you just address the coverage for mental health? We've talked about a lot of things, and I'm kind of assuming it's there, but I'm at a point in my life where I'm assuming nothing anymore. I just want to hear somebody say, yeah, there is vigorous mental health coverage for folks.
Yeah, so I want to, again, be very clear that mental health coverage is included in our legislation to ensure that we have a single payer healthcare system here in the state of Rhode Island. And again, mental health parity rates are something that needs to be addressed within the state budget to actually make sure that we have the financial support to do it. And it's been, as you know, Donnie, it's been a fight that's been happening at the State House for years in terms of what are the reimbursement rates for mental health? How are we going to actually increase it? And I think we're continuing to build the momentum, especially as a result of the COVID-19 pandemic, where people recognize mental health is just as important as physical health. It always has been, but thankfully our government is now starting to recognize that. And for that, again, want to be very clear and provide that clarity that mental health would be covered within this Medicare for All system.